right, everyone, welcome to chapter 28. We're going to be continuing the neuromuscular conditions section of this class, and today we're going to be talking about multiple sclerosis or MS. So a couple of quick facts for you about MS. Usually people are diagnosed between the ages of 20 and 40. And it affects a little fewer than 1 in 1,000 people, and that's roughly 2.5 million people worldwide. It's a lot more prevalent in females, so about 2 to 3 times more prevalent. And experts believe that a combination of environmental factors, including decreased vitamin D, the Epstein-Barr virus, and smoking, lead to the development of MS in people who are genetically susceptible to it. So, why don't we start with the basic pathophysiology of MS? So, it's an autoimmune disorder that affects the central nervous system or the CNS. And it's a process that involves an immune-mediated attack on the myelin sheath of nerves. So if you go back to, either biology or physiology or wherever you may have learned about all of this, the myelin sheath helps with conduction of the nerves. So when your brain is telling you to do something, like move your arm, move your leg, it's really helpful that when it initiates that, it reaches the limb as soon as possible, right? So if MS starts to attack the myelination, then you can imagine that there are going to be a number of problems. So either just the synapses are not going to function the way they're supposed to, and overall movement is not going to work the way that it should, and the way that it currently works for people who don't have MS. A combination of plaque formation and demyelinization or demyelination causes fatigue and gait disturbances, among other symptoms. And some of those are stuff like spasticity, changes in sensation, visual disturbances, cognitive and emotional impairment, sleep disruption, loss of bladder and bowel control, and then depression and decreased functional ability. So it essentially affects, everything on the spectrum, right? Now, MS can be classified into four different types, and most people do fit into one of these four categories. Even if, um, the effect of MS looks different for them, it usually follows these patterns. So the first one is relapsing remitting. This is when symptoms appear and disappear, but there isn't any progression of the disease, so it doesn't get worse, per se. So it just comes and goes. And then we have primary progressive, so there's no remission, and there's a gradual progression of the disease, so it keeps getting worse. The secondary progressive group, it begins as relapsing remitting and then becomes progressive. And then the progressive relapsing group, it progresses steadily with intermittent severe episodes. Now, it goes without saying that unfortunately the cause of MS is unknown and there's currently no cure for it either. So hopefully, eventually we'll have, another group where, they'll start off with MS and then eventually recover, maybe sometime in the future, but this is currently what we have. Okay, so how do people manage MS and how do they medicate for it? So, like the other syndromes that we talked about in the last few lectures, there are a number of things that need to be asserted before actually being diagnosed with MS, and other conditions need to be excluded. So, there are three key features necessary. So, they have to have two clinical attacks, they have to affect separate areas of the CNS, and they have to occur at two different times. Now, an MRI can be used to identify exactly, what's happening and where it's happening because it's really sensitive at detecting plaques. Um, but I mean, the tough thing about this is sometimes people will have, kind of like the silent strokes we talked about, they may have silent attacks of MS, and it may only manifest as fatigue. So, they deem that, oh, I'm not going to go and get this checked out because maybe they don't know what it is, right? Um, so anyway, diagnosing it is interesting, but these key features are necessary for it. And then once people are diagnosed, there's a way to calculate severity. So there's two different ways, but we're mainly going to talk about the second one, or the Kurtz Expanded Disability Status Scale, or EDSS. Now, the textbook for this in chapter 28 has the full table listed with exactly what the description is of the functional status. But in general, it ranges from 0 to 10, with 0 being normal and then 10 being the most severe death from MS. And each one increases by an increment of zero point 0.5. Now, a little bit to just get context of what functioning is like on this scale. Um, People who are at a value of 4 can typically ambulate without aid for about 500 meters, and they're mostly independent when they do ADLs. Anyone who is above 5 starts to have some limitations in completing their ADLs. So that's just the very general breakdown of it. But again, if you want like exactly all of the levels to the zero point 0.5 scale, then the textbook's really helpful for this. So treatment is focused on both disease and symptom management, and because it's so different for each individual, and because it differs so much within the individual, like, their symptoms may be completely different 1 year apart or a couple months apart. Um, Managing it is pretty challenging. So for acute attacks, the general strategy right now is to give high dose intravenous glucocorticoids to reduce inflammation within the CNS. Um, but between relapses, there are various other medications that they take that work with different mechanisms. So this is another massive table in the textbook, and I highly recommend you check it out because if you do work with people with MS, they're most likely taking some of these medications. And the table in the book is really, really helpful for this. Um, and also, it lists all the adverse effects that these medications may have, and you should consider them if you're going to work with them as an exercise specialist. So, I would list it, but there's a lot. So, see the textbook for details for that one. Also, they may be taking various medications that aren't specifically related to MS, but just related to the symptoms of MS. So stuff like depression, fatigue, spasticity, pain, bowel and bladder dysfunction, and endocrine disorders. Um, so yeah, this is one of the groups that's definitely going to be highly medicated. All right, so what effect does MS have on the exercise response? Well, because I guess the severity of MS is so different within people in the same group and individuals within the lifespan, it's gonna show really differently for everyone. So in general, these are four things that we see. We see dyspnea on exertion, exaggerated pressure and chronotropic responses, weakness and easy fatigability, and low thermal stress tolerance. And we'll touch on that last one a little later. Now, most MS patients live a relatively sedentary life, and they actually they are well very deconditioned, like many other conditions we've talked about, but they have reduced muscular and cardiovascular fitness as compared to the general population. And if you remember from way back, the first few lectures, the general population is also not meeting exercise guidelines. So that just kind of puts into perspective the level of deconditioning that you may be working with for this population. Um, so, what are some effects of exercise training? Well, until recently, experts thought that exercise was relatively contraindicated for the MS population. However, some studies have been showing that aerobic exercise increases peak oxygen uptake or peak or VO2 peak. And then endurance and resistance training can help reduce negative effects of MS, of movement and physical functioning. And of course, I'm not listing it here because we've listed it a million times, but all of the other benefits definitely also come from exercise, things like increasing their mood or just helping with very general physical functioning, ADLs. So these are just some specific MS related ones. However, something that you should know and maybe also disclose to your patient is that they may experience a temporary worsening of symptoms right after exercise. Um, Thankfully, this clears in about half an hour, but it's just something that they should know and not freak out about. However, like many other conditions that we've talked about, there are other aspects of exercise and how it relates to MS that are unknown. For example, it's not known exactly what type of exercise and what intensity and frequency would help this population the most. And especially for the higher classifications of MS on that EDSS scale, so about 7 and above, there's actually not much known about that. So, how exercise actually affects them when they're, more like further along through the course of MS. So there's still some room to improve, but that's just where we're at right now. Okay, exercise testing. Should you do it? Should you not do it? Well, um, hopefully the severe deconditioned part that I talked about kind of, you know, led you to think that, yeah, maybe maximal testing is not a good idea. And it's definitely not. Another reason it's not recommended is because remember how a lot of them are medicated? Well, some of them have a high dose corticosteroids, and that increases the risk of osteoporosis in them. So we don't want them going to the max. However, the CDD4 submaximal testing procedures are definitely a pretty good choice, and it would help to just know where the patient is starting from. Additionally, balance, sensation, and flexibility testing can also be important to assess because these measures are typically compromised and may guide elements of the training program, maybe things that you should focus on for them. And just a practical note here, where we talked about, the heat stress portion. So their performance may be diminished if testing occurs later in the day or in hotter climates. So just note that and maybe try to schedule around that if you're going to do a submaximal test. Okay, and lastly, let's talk about exercise programming and recommendations. So the general guideline here is stick to the CDD4 recommendations. Those are definitely appropriate for this population. In general, kind of like the fibromyalgia and CFS populations we talked about, it's definitely best to go pretty slow with this population. Now, there isn't that same risk of, oh, they may overexert themselves, so just watch out for that. But you just want basic functioning and to help them maintain that level. That's the main goal. So doing too little is perfectly fine for this population, and maybe it's wise to err on that side instead of like pushing them, for example. But here are some more specific notes. So exercise should begin at low levels using a familiar activity and be gradually increased. Short bouts of exercise with varying intensity and duration can be completed during the day. Recommended activities include yoga and aquatics and stuff like, oh, that's funny. The I didn't catch that. Activities like yoga, aquatics, and therapeutic horseback riding can be considered. Uh, the publishers didn't catch that one with the slides. Um, Anyway, next ones. If experiencing a relapse or not feeling well, the client should listen to their body or skip the day. That's perfectly fine because, as we talked about, it looks different for everyone. So don't push if it's not the right day for it. Here's another heat stress consideration that you should take. So, certain activities that increase body temperature, you should take caution to avoid it in warm conditions. Now, if it's serious enough to the point where, the specific patient is having a lot of problems with this, then you can even avoid aerobic exercise and just stick to resistance because that doesn't increase body temperature as much as aerobic exercise does. Um, Try multiple short bouts of exercise during the day, varying intensity and duration. Also, a specific one that you definitely should do with them is sit to stands and step ups. They're really useful to try and maintain lower extremity um, function. Also, the textbook makes a really good suggestion here that supervision should be a part of this when you're working with someone who has MS. And it's needed for three reasons. So first, to select the best exercises for the person's individual needs. Second, to ensure that the exercises are performed properly and safely. And third, to offer counseling for support and to help overcome fear avoidance. Um, so yeah, those are just some of the recommendations, and that is all I have for the slides. So um, yeah, hope you learned something new, and I will catch you in the next chapter.